welcome everybody to this 13th session of the Global Sepsis Lecture series. To remember this lecture and all our lectures are recorded and made available on our website and on YouTube. So feel free to rewatch the lecture, and on our website there are a lot of different other materials about sepsis in low and middle income settings. So we are really happy, for you to visit this website. So as we know, one part of the STAIRS network task is to implement telemedicine in telemedical intensive care and build local capacity for telemedicine and teleconsultancy. That's why our topic today will be the basics of telemedicine and its use for sepsis care around the world. This webinar will be part of maybe a series of different webinars about telemedicine. And for this, we are really, really happy to welcome our expert at STAIRS in this topic. This is Dr. Wiltrud Abels. Dr. Abels is a senior consultant in anesthesiology and intensive care medicine at Charité University Hospital in Berlin. She is team lead for sepsis at the Charité Center for Global Health, and she is co-lead of STAIRS Charité. Research focus are on telemedicine, capacity building, and quality improvement in sepsis care. So I won't talk further. Wiltrud, I give you the word, and thank you so much for this lecture. Looking forward to it.
Thank you, Ellen. Thank you so much. Thanks for having me today. Yes, for the kind introduction also. Yeah, my name is Wiltrud. I'm actually working, as Ellen said, at the Department of Anesthesiology and Intensive Care. As an addition to this, we do host a telemedical ICU at our department. I used to be part of that for quite a while. And in the STAIRS project, the ongoing sepsis research project in Sub-Saharan Africa, we are actually exploring the use of telemedicine for expedited sepsis care and for better sepsis management, and also for capacity building around the topic. And as you probably all know, this series is part of it. And the telemedicine topics, which we are today kicking off as part of the webinar series, are supposed to make people aware of the options that telemedicine can be. And what I want to achieve today is that we together look at all the options that telemedicine offer to you. I want us all at the end of the session to be aware of the most important definitions of what telemedicine actually is. I want us to see that, or I want to convey to you my view that telemedicine is kind of a toolbox because it can be many different things. So we will be looking at different modes of telemedicine. We will be taking a brief look at the most common challenges in introducing a telemedicine program, or the pitfalls that you have to think about if you want to come up with your own telemedicine program. I want to highlight the importance of defining your use case above everything, even above the choice of technology. It is important to define what you are going to use the telemedicine for. And at the end, I am, as an example, gonna show you a little bit of what we are at the moment trying to implement in the STAIRS project in terms of telemedicine for improved sepsis care in Sub-Saharan Africa. So bear with me. This is our program for today. And I want to start with terminology, actually, and with definitions, because I have very often found that there is a lot of confusion around all the different terms related to telemedicine, telehealth, digital health that float around. When I talk today about telemedicine, then I am talking about the use of information and communication technologies that is used and used by healthcare professionals in direct patient care or to support or augment direct care processes. This is the narrower definition of telemedicine in accordance with the WHO Consolidated Telemedicine Implementation Guide. These documents are important framework documents, and I'll keep highlighting these documents because they are actually a great help if you want to, as a provider, think about how to use telemedicine in your own context for your own purpose. Telemedicine includes, again, several things. So it also is an umbrella term. It can actually include learning or distance learning for healthcare workers, for professionals in healthcare. So, for example, what we're doing right now would technically also count as some sort of telemedicine. It would even more count as telemedicine if we were today to discuss a specific case, or if a provider would get in touch online to discuss with another provider, maybe with a specialist, a remote specialist, about second opinions or specialist advice on a specific case. So this is also telemedicine. Telemedicine can also be teleconsultancy. So the meeting of a healthcare provider online through a dedicated technology, either with another provider or with a patient. So both of these things are possible, and this already opens up a lot of possibilities, and all of this is telemedicine. Today, we are eventually going to focus a little bit on an integrated approach with several modules, and I'm mainly going to talk about provider to provider telemedicine, which is then teleconsultancy, and about distance learning. And this is just for us to be on the same page in terms of terminology. So what is telemedicine? There is actually a definition provided to us by the World Health Organization. Telemedicine is the delivery of healthcare services wherever distance is a critical factor. Telemedicine is provided and meant for patients, but also healthcare professionals. But the main point is that it is not something that is done by physicians alone, but it's a interprofessional thing. So all healthcare professionals can be involved in telemedicine, and that's an important part for some use cases where, for example, sepsis, where the success of the management very often relies on a clinical team and not only on one specific person. Telemedicine always is using information and communication technologies. And what I want to highlight here by giving you like different examples, for example, the Zoom platform that we are on right now, or a exemplary conversation, a mock conversation that I had with my clinical colleague at Charité a while ago on WhatsApp, or on the right side, bottom right side of this slide, or alternatively, on the left side, the bigger picture, a dedicated bedside usable telemedicine technology with an audio-visual communication channel where the remote expert beams onto a device that can at the same time convey what he says, but also is able through camera lenses to observe what's happening at the bedside with the patient in the interaction with the attending physician and the patient and the team around. So there is different technologies that can be used for telemedicine. And as I said before, while this is of course, an essential part of telemedicine. There is maybe even more important parts, which is to decide what am I going to use it for, which then has a direct effect on your choice of technology. Telemedicine is always used for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries. So that's very broad. And I very much recommend to, when you come up with your own telemedical approach, to sort of think about how this part of the sentence, or maybe all parts of the sentences of this definition, can be changed so it reflects your use case. So in our case, we have, when we started building our approach, changed this part of the sentence to a little bit of a different phrasing. And we are in the STAIRS project using telemedicine for the exchange of valid information for early diagnosis, timely treatment, and prevention of sepsis, including the exchange of recommendations provided by a remote specialist from a referral center. And also including the exchange about referral, the need for referral, upward referral for a critically ill patients. This is what I recommend. Is my first recommendation today is that if you think about your own approach, think about this part of the sentence and how you would change it to reflect what you want to achieve with your telemedical approach. Telemedicine is then, and this is the last part of the definition, always conducted in the interest of advancing the health of individuals and their communities. And I think this is last but not the very least part of this sentence. We always need to keep in mind that we are doing telemedicine not for the purpose of having a cool new gadget, but to advance the health of our patients and to make sure that the quality of treatment, the quality of care is improved by using telemedicine. So I said I was going to talk about different modes of telemedicine, and this is a little bit of a visual representation of what telemedicine can be. I already mentioned that remote teaching and training, peer-to-peer usually, including webinars, including case discussions, leading to a valuable knowledge exchange about care, in our case, sepsis care, is already telemedicine. So what we're doing right now, our webinar series is already a mode of telemedicine. And in our tele-ICU, we have made the experience that it's actually valuable also for building the team, building the core team to start with these kinds of teachings and trainings and exchanges online on a regular basis, because this is what then keeps or lets the team grow, and also is an opportunity to discover specific topics of interest and discuss specific cases that are specifically relevant for learning or for capacity building. If we go one step further up I want to say stairs of modes of telemedicine, then the next step would be to have remote experts come and join a synchronous case discussion. So while the treatment is still ongoing, to get in touch with a remote specialist, an expert that then provides second opinion on the ongoing treatment. This can happen at the bedside, so at the point of care. It can also be away from the bedside, but the closer it gets to the bedside, the more we are getting into high dependency and acuity settings, for example, intensive care units, but also emergency units, where then the technology needs to be a little more sophisticated, but still usable, to be used, for example, in daily rounds at the bedside or in case discussions at the bedside, and this can then also be an exchange between providers, but also include the patient, of course. So we have different modes of telemedicine, and we need to keep this in mind when we think about whatever we want to use the telemedicine for. I want to talk a little more about this audio-visual connection that is possible through different kinds of technology for peer-to-peer teleconsultancy at the bedside. So I've brought you like different examples here. You see different setups of a dedicated technology that can be used for communications to between providers at the bedside. Connection for this, obviously, all of these need connection to the internet. The technology is evolving quickly, and today we can have these connections via Wi-Fi, but it's not even necessary to have like a high functioning Wi-Fi with big bandwidth at your hospital, but you can also use in the meantime cellular data or even satellite-based internet. So when you build your approach, it's obviously an essential thing to think about: how am I going to connect? How am I going to achieve stable connectivity for my teleconsultancy solution that I'm picking? But in some of these settings, some of these setups, especially on the left side, if you see, that's like a very a big machine that has a lot of possibilities to also connect accessories, for example, stethoscopes or sonography, to it. That's obviously comes with a little bit of a higher cost, but these things are possible. If you want to have that, if you think that it is worth having these things in the exchanges that you are planning. Others are more, let's say, maybe flexible, but offer less of these additional gadgets. What's important to say is that in principle, several companies, like many companies, offer technical solutions. And one of the exercises in building a telemedicine approach is to think about which one of the solutions do I want to use, which makes sense in my setting, what's my price range, what's my budget. I was actually not really able to give you an exact figure of how many different platforms for provider to provider teleconsultancy there is in the world, because there's no single source for this information. But I did ask AI, so I put a prompt into ChatGPT, and even ChatGPT couldn't come up with this number and only said that we have several hundred, at least 250 to 500 different platforms that offer solutions for patient to provider to provider teleconsultancy alone. Essentially, what I want to say with this slide is that it is, at the end of the day, not about the technology that you pick, but about how you use it. So telemedicine and all the platforms available, I think the best way to look at this is as like you're looking at a toolbox. And then for the thing that you're building, for the purpose that you have in mind, pick the right technology that serves your purpose best. Just looking a little bit into what has been published and what is known about the benefits of provider-to-provider telemedicine. As I said, there are valuable documents available, guidelines and recommendations. For example, the 2019 WHO guidelines that gives recommendations on digital interventions for health system strengthening. And in this guideline, you find this recommendation about provider-to-provider telemedicine. And it has been found, and this is based on literature review, for like mainly in qualitative evidence, that healthcare workers appreciate the opportunity to have P2P telemedicine to communicate with each other. It reduces professional isolation, especially in settings where there is a lack of specialized healthcare workers. And it's in particular lower level healthcare workers who say that telemedicine services allow them to access advice from a higher level, which then eventually allows them to provide a better quality of care and serve their patients better. In fact, there is not yet a lot, but growing evidence that P2P telemedicine can improve healthcare worker performance. It can reduce the time for clients to receive appropriate care or follow-up care, which is something that we have very much in mind when we think about sepsis. And it can also decrease the length of stay in an emergency department. And this is one of the indicators that obviously every hospital is interested in achieving. Telemedicine is also has an element of improving gender issues and inequities by the sheer accessibility of it. So telemedical interventions may improve equity by enabling healthcare workers to facilitate said access to higher level care for their patients. As a summary, the guide then summarizes the existing literature into the following two sentences. Digital approaches, and most notably telemedicine, have emerged as a potential way to overcome the barriers of long distances and alleviate the challenges that we sometimes face due to a lack of qualified healthcare workers and shortages of these qualified healthcare workers in some places. Healthcare workers like telemedicine, and this is for several reasons. They are able to get assistance with diagnosis. They are able to conduct case management consultations with a higher level care. And this all can happen, as I said before, synchronously in real-time exchanges while the care is happening. But it can also happen in case discussions away from the bedside, asynchronously. This is just one example, and I'm only highlighting this because I want to also take a little step further and highlight that telemedicine can be a tool for quality improvement. And this is something that I think is a very good way of looking at telemedicine and also at looking at the evaluation of telemedicine. I've brought a study that was conducted, I think, before the pandemic, even in 2018, from our telemedical ICU. This is in Germany. It's not the study itself is in detail not of interest for our context here, but what's interesting is that we were able to suggest out of the data that we found, namely that we were able to improve the adherence to certain quality indicators in critical care, that telemedicine could be used to increase adherence to best practice guidelines and indicators of process quality, and therefore can be a tool for quality improvement. And again, this is something that I very much recommend anyone who wants to think about using telemedicine in their setting. Think about, how can I use telemedicine to improve the quality of care that we are providing for our patients? Now, I've talked a lot about planning your own approach, and I kind of later on in the question and answers, if we have the time, I would very much like to hear your take on telemedicine and maybe a few ideas and questions, because I believe that it's at least a good thought experiment to think about your own sort of ideas of how telemedicine can be used. And if you really get on doing that, if you really get on building an approach, then I very much recommend going back again to another guideline document, another framework that has been provided to us by WHO in 2022, which is the Consolidated Telemedicine Implementation Guide. This implementation guide kind of gives you a roadmap for the steps that you need to take in order to build a useful, measurable, and doable, feasible telemedicine approach. As you can see, there is very roughly three phases, and you start by preparing, you start by assessing the situation that you are in, you start by forming a team and defining your goals, defining your program context. What am I going to use the telemedicine for? What's my use case? I'm going to keep using the word use case. And what I mean by that is, what am I going to use telemedicine for in this case? You should, according to this guide, conduct a landscape analysis, see what's the enabling environment. Is there, for example, as we have found it in the African countries that we work in, is there, for example, a political will and an agenda to introduce telemedicine into general healthcare? So are there maybe stakeholders on the political side of things that can help us to push this forward? Once we have done the situational assessments, we then move into planning the actual implementation. And this is when you get into the midst of things and determine the details within the team that you formed, like with eyes on the goals that you have set, where you determine how the telemedicine system will actually operate, which telemedicine system will I be picking, what are my standard operating procedures for exchanges using the telemedicine, what is it going to cost, and how can I engage clients and patients safely and in a way that also respects inequities. And the third phase is something very, very important, and also the reason why I highlighted that I think telemedicine can be used as a quality improvement tool. You do want to be able to monitor the implementation of telemedicine. You also want to be able to evaluate if it works, and maybe even during the implementation have like an ongoing process evaluation of how it is going in order to be able to make adaptations when you see that certain elements don't work and need adjustment. So what you need to do is you need to determine your goals for monitoring and evaluation. So this goes directly back to the goals and the key targets that you hopefully have defined in the first place. So what do I want to achieve? What are, for example, the quality indicators that I want to look at if they are changing before or after the implementation of telemedicine, for example? And what's my plan for then having this long, like run in the long run? And what's my plan for continuous improvement and adaptation of the approach whenever this is needed? Again, this is from the Consolidated Telemedicine Implementation Guide. I very much recommend this document. So I'm slowly moving towards giving you an example of how we did it for sepsis care, or how we are looking at doing it right now in our research network in STAIRS. And as you have seen, there's a lot of things that you have to consider before. And also first of all, we went and did our homework. And as so many times, this goes back to looking at literature, looking at available publications, and see if maybe other people before have identified challenges and room for improvement concerning telemedicine, concerning the implementation of telemedicine on the Sub-Saharan African, on the African continent, and especially in Sub-Saharan Africa. So we have found several publications. This is by far not everything that's out there. There's, in the meantime, there have been updated reviews, but what authors very much agree on is that what's our common pitfalls when implementing telemedicine in Sub-Saharan Africa is that there very often is a lack of internet connectivity, unstable electricity, that there is in many places a lack of experience in working with digital technology in healthcare. That is sometimes technology is set up in ways that is very unsupportive of existing workflows, and therefore it turns out to not be really usable or feasible for people. in some pilot projects there has been a lack of buy-in from stakeholders observed, and then there are also and this is a very important part, and I recommend everyone to conduct qualitative studies to really look at these sort of human factors, soft factors like resistance to change. Some people just need a little longer to embrace new technology, especially when it comes to healthcare. There's sometimes language barriers that need to be overcome. There is, after all, varying cultural contexts and perceptions, for instance, about what role technology should play at all in treating illnesses and in healthcare. And there has some qualitative studies even have found that some people perceive the introduction of digital technologies and telemedicine as a loss of human touch. These are things that need to be considered. I personally think these are things that can be overcome. And there's also good news from all of these studies. What we need to overcome these barriers and what we need to, after all, build like a successful telemedicine approach is usually sustained collaboration with external parties. So this can be international partners who have experience in introducing telemedicine, but this can also be specific information communication technology providers that operate nationally, which also then has the advantage of bringing costs down. You do need buy-in from stakeholders. This is also external parties. You definitely need a good, appropriate technology for the use case that you're defining, for the team that you're working with. Again, to stress this point, it's not about the technology, it's about the use case and the team that's going to use it. You need standard operating procedures. This is very important, and this also serves to really think about patient data protection and the ways that you are going to conduct the telemedicine in order to pay respect to data protection. And also to pay respect to evidence-based recommendations. You need a systemic approach and planning. As I said short before, there is help for this. There is, for example, the Consolidated Implementation Guide, and you need ideally ongoing monitoring and evaluation in order to see if your approach works, and when you see the need that you can adjust whatever is not working in your approach. So with this, I am already coming to the point where I'm going to highlight a little bit of an example, how we went about and built a telemedicine approach with the use case of improving the quality of sepsis care in Sub-Saharan Africa. We are doing this within the framework of a research network in Sub-Saharan Africa. It's called STAIRS. It's 7 countries. But the telemedicine approach is a pilot project that is conducted in 2 of the partner sites in Ethiopia and Ghana. And we are very happy to say that we have great support and an ongoing collaboration with the African Federation of Emergency Medicine in this approach. So again, going back to planning, going back to the steps 1, 2, 3, 4 in the implementation guide, we did our homework, and we specifically thinking about sepsis management in resource-limited settings. We looked again at literature, we looked again at publications, and we mainly found that up to this point, there is one of the biggest challenges is that there's actually a lack of evidence that telemedicine is able to improve patient-centered outcomes. We need evidence. We need to do this pilot to show if it works. That's the first question. Does it work for improving sepsis care? Authors have so far always found that telemedicine potentially comes with high costs and infrastructural challenges. This is very much in line with the other studies that I showed before. There's sometimes a lack of stable internet connectivity, especially in more rural hospitals And this is something that needs to be thought about when introducing a telemedical approach in a setting like this. Um, and then again, everything we do in STAIRS is centered around the patient and the patient pathway. And what we know, and this is now, I think, in my personal opinion, the most important point of the process of building a telemedical approach is thinking about what do I want to achieve, which patient is the one that I want to like which management part of sepsis management is the one that I want to support. And also here we're going back to literature that tells us about the patient pathway. On the left side of the slide, you see a publication that has nicely in 2018 laid out the sepsis patient pathway. So the way that a typical sepsis patient is taking from the home, getting sick, getting to the hospital, getting treatment, hopefully surviving the medical emergency that sepsis is, and then being discharged again to the community. And it has highlighted all the challenges and infrastructural, but also technical challenges that can happen on the way. And there has also been in a little bit earlier even, but also in close connection with this way of thinking about the patient pathway in sepsis, a 3 delay model that's also been published that highlights certain typical delays in, for example, triage and diagnosis for sepsis patients in the early management, so in the first phase of management of sepsis, which needs to happen quickly because sepsis is a time-critical disease. And outcomes very much depend on the speed of treatment, and a 3rd delay in the area of monitoring and reassessment. And keeping all of these things that we know, all of these challenges along the patient pathway in mind, we then went on to define what are the 3 most important things that we want our telemedical approach to improve. And first and foremost, number 1, patient pathway. We work patient-centeredly. We want to eventually improve the health of an individual and of sepsis patients and improve delays in sepsis care. So the first thought was, at what point of the patient pathway can we maybe have an influence on delays in sepsis care and maybe improve delays in sepsis care best with telemedicine. Another thing that was very close to our hearts and also is something that it needs to be supported is capacity building in clinical teams, because going back to this publication from 2018, it was found that especially in smaller hospitals, there's understaffing, underfunding, and also a lack of specialized healthcare workers. So the team sometimes lacks specialized expertise and training and education, especially ongoing training and education. And our question then was, how can a telemedical approach be built to improve this? And the third thing that is last but also not least here is, how can the system be supported? So we know that sometimes referrals of these critically ill sepsis patients don't happen in time. Referral systems are not always strong. There is lack of capacity, lack of ICU beds, lack of pediatric ICU beds, which then again makes speedy diagnosis and treatment very essential. But we also were thinking about, how can you optimize the systems of referral, for example, between primary care centers or secondary hospitals, smaller hospitals in more remote areas, to the referral center in the region. So the third sort of broader target and aim of our telemedical approach was to determine an approach and telemedical approach that can support timely and appropriate referral to like a higher level care when the patient needs it. And I'm just to give you some impressions. We did follow the implementation guide. We did our situational assessments, and you see here many of the people that are involved in this approach. The amazing teams in Ethiopia and Ghana, who are the teams, the local champions. With whom we got together also in a workshop in Berlin and established our goals, determined how our telemedical system then will operate, picked the platform that we're going to be using, and defined standard operating procedures. And last but not least, came up with a monitoring and evaluation approach to see whether or not our telemedicine approach really works. Um, I just want to look like in now, what is it? So what are we then specifically doing? We actually decided that our telemedicine approach would work in a modular way. So we would draw from all the different modes of telemedicine and start and lay the basis for capacity building and addressing the need for capacity building in clinical teams on some levels of the healthcare system by a webinar series open for an interprofessional audience for clinical capacity building. We then went on to pick another mode of telemedicine, namely a dedicated audiovisual platform for telemedicine, provider to provider, that can be used at the bedside in time with clinical care to connect in specialists in country, in referral centers in country, from emergency units, mainly from emergency units and ICUs, to more remote secondary hospitals, in order to give an opportunity for expert recommendations in hospitals that have maybe a lack of specialized healthcare services, and with this support, become able to correctly treat or correctly perform the initial management of a sepsis patient, even in the smaller hospital. So recommendations, but also the discussion of referral needs, so that in fact the lower level of the healthcare system in a way moves closer to the referral centers in terms of getting support in terms of care, but also in determining the need for a referral when the patient really needs it. The third part of this modular approach is eventually the smallest part of things, but it is still very valuable. We will also have an ongoing collaboration internationally between these referral centers, where the experts are learning to use telemedicine for giving recommendations to secondary hospitals and smaller emergency units. We will, from the side of the Charité Tele-ICU, stay in touch, especially in the area of intensive care unit, because this is our, I want to say, core business. And this then goes to an element of critical care capacity building, which is also a valuable target in sepsis care in Ghana and Ethiopia both. So our aims are to work or address the lack of continued professional training for clinical teams. And this is not only physicians, but this is interprofessional teams. We do a webinar series for this. We also do we use the teleconsultancies at the bedside, and also in the future case discussions with the specific hospitals as educational tools, as sort of knowledge exchange about specific cases, but also as a tool to continuously build expertise around sepsis. We're also going to use the dedicated technology to improve early recognition and triage, mainly in country, so that smaller emergency units are supported by specialists in the referral center for sepsis management, with an aim to primarily reduce delays in sepsis care by again, facilitating early recognition and triage and supporting early management, and also facilitating referral to, like a more quickly referral to a higher level of care whenever that's needed. So this is the modular approach that we're taking, drawing from the toolbox of telemedicine, always keeping in mind our use case, always keeping in mind our key targets. And we are the last element that I also highlighted before is that this is a pilot project, and we want to honestly look at it and ask ourselves, is this working? Is this worth it? So we came up with a monitoring and evaluation approach, and we're going to evaluate the establishment of the telemedicine in the referral hospitals and the secondary hospitals in a mixed method approach. And we're going to treat it as a quality improvement intervention and measure the quality of sepsis care before and after in an intervention study. We are also going to evaluate levels of sepsis knowledge in a more broader way. This is going to be a survey study. And last but not least, we are during the whole process, we are going to look at the implementation, and we're going to get together in the core teams again and again and do repeated process evaluation meetings in order to see whether or not adaptation is needed in one or another module of the approach. So this brings me to the summary. Looking back at the beginning of my talk, we looked at terminology, and we realized that telemedicine has a very broad definition. We then went on and saw that there are actually numerous platforms for conducting telemedicine, especially also for provider-to-provider telemedicine. It's also true for provider-to-patient telemedicine. And I want to highlight again the point that the most important factor when you pick a platform for telemedicine is, what do I want to achieve with it? What is my use case? I always give the recommendation to adapt the definition, like the official definition of telemedicine given out by WHO, like play a little with the words and adapt the definition to reflect your own use case. This can be very helpful as a step on the way to finding your use case and to finding the way that telemedicine will work for you. I very much recommend to follow accepted published recommendations, such as the WHO frameworks, like the Consolidated Telemedicine Implementation Guide. There's a QR code that links to it. And I, again, as one of the very first steps, I think that it's very important to assess the telemedicine readiness in your in the place where you want to introduce telemedicine. So ask yourselves honestly, and ask the teams that are going to use with the telemedicine that you're implementing, how acceptable is this technology? How usable is it? How can we implement it best to support existing workflows and improve quality of care? A little bit of an outlook. This is just to give a little bit of an outlook towards hopefully part 2 of the telemedicine topics in the Global Sepsis Lecture series. We have invited some distinguished speakers from the US for one of the next sessions. And we are going to hear about even more creative and other modes of telemedicine, namely telesimulation for sepsis care. I'm very much looking forward to that. There's a study that's worth looking at if you're interested. This is bringing together established and great training method, namely simulation, together with telemedicine, and to merge into something called telesimulation, which can be a great mode of capacity building also for sepsis care. And we are looking forward to receiving a talk about this in the near future in the Global Sepsis Lecture series. So please stay tuned. With this, I would like to thank you very much. We still have at least 10 minutes for questions if you have any. As I said before, I would be very happy to hear about your ideas and take your questions about building your own telemedical approach. And if you don't find the time to post the question now, you can also always drop me an email. I think my email was pretty much on every slide in this presentation. Thank you so much.
Thank you so much, Wiltrud, for this wonderful overview and also sharing your own experience with the implementation of telemedicine. That was wonderful. Thank you so much. And yeah, so happy to receive questions if you have. You can also write them in the chat. Mm, maybe I can start with one question of interest, I guess, for our colleagues. How do you handle medical legal responsibilities when remote clinicians advise frontline staff in sepsis emergency? How did it work at Charité, for example, taking your experience from Charité? Yeah,
Yeah,
that.
that's a brilliant question. Because obviously, if you start to involve another clinician from another institution in your clinical care for a patient, then the question is who is eventually going to be responsible for the treatment of the patient. I very much recommend the following, and this is how we've done it always in all the projects that have been conducted at the Charité Tele ICU, is that you agree beforehand with the site that you're conducting the telemedicine with that the immediate responsibility for the patient always remains with the attending physician on site. So the physician that calls out for a second opinion or an expert recommendation is not giving away responsibility for care, but rather takes the opportunity to get recommendations from someone who might have more expertise in a specific discipline or specific question. But this is all it remains. It's recommendations. And legally, it's not binding. I very much recommend to set up the contracting around these things in a way that treats the expert and specialist recommendations as such and not as sort of binding orders for example, changing treatment.
Thank you so much. Thank you. Another question. We have one colleague who had connectivity problems, so do not worry. This session would be uploaded on YouTube, so and in our on our website if you want to read it again. Okay, so I guess there is no other question as I can see.
I'm very happy to take questions anytime, also online or via email. If that's if you feel a need to reach out, please do.
Thank you very much. Okay, so I think we will now end the session. Thank you so much for your time, Wiltrud, and thank you so much
Yes.
everyone for joining. And we
Thanks.
see you in 2 weeks' time. We will get an invitation for the next session. Thank you so much.
Thank
Bye
you.
bye.
Thank you very much. Bye.
Bye.